Assalamu alaikum. Jazakumullah khair. Thank you for waiting for this presentation. And actually, as Dr. Wael Kashkari was mentioning, that we will put like a GPT or a car as a gift at the end of this show, so people will be attracted to this meeting. So I would like to thank the organizing committee to give me the chance to talk about this topic, which is actually, I was lucky enough to be in the SKY meeting last week when they presented the new recommendation with the PFO closure. So I think it's a great opportunity for me to present and review some of this topic to you. Started with a case scenario, a 32-year-old guy who presented to our hospital. He's a horse rider, horse trainer, that he's been having multiple fractures and also some presenting to the outside ER 6 times with a history of weaknesses in multiple occasions. Presented to our ER on the 7th presentation, and we started him on a different workup regarding this weakness that he's having. A PFO, I'm just going to go over some of the anatomy, just to review some of it, but I will concentrate mainly at the cardiac point of view, where is the cardiac workup and the intervention and the workflow and some of the new insights that came with the new publications. So it was actually firstly described, if you go to the literatures, by actually Da Vinci itself, where a description was written, I have found from A, left auricle, to B, right auricle, the perforating channel from A to B. So it was initially actually described early in 1513 about the presence of a PFO. So it's basically the embryology and the way they started the septum primum first, subsequently the secundum development and fenestration happens, and this is how the embryo start, and then there will be like a valve-like appearance or a door-like appearance, where basically a right to left shunt occur in the embryo. Subsequently, this will close and heal. Unfortunately, the patency can up to be 25% after that. Just in a summary, I know Dr. Wael Kashkari mentioned, but just to some of the anatomical variation from atrial septal defect and PFO. From the PFO, basically, is mainly the differences in the shunt level, which is mainly a right to left. The embryology, the presence, as I mentioned to you, up to 25%, and the consequences for it is the PFO most probably is an incidental finding unless if it's associated with other problems. But the ASD usually is a left-to-right shunt with a heart failure. So we'll just try to go over some of the cardiac workup. If you look just historically, when the PFO closure from the interventional perspective, from 2012 until now, it went into a waveform from being an aggressive closing all PFOs, weaned down to basically not really favorable of doing it, until recently with the more of an updated from the old studies for pushing for some of a selective and more insight regarding when and how to close this defect. Not only that, but also the neurology group, which has been more proactive, more aggressive with this, and putting out guidelines, which included from a lot of input from cardiologists in the 2021, including the valvular lesion, including the PFO, including other stroke related to cardiology. So I would recommend everybody to go over it. It's very extensive roadmap, but it's actually has nice schematic diagram that will ease going through it. So just going through a lot of causes that can, from a cardiac point of view regarding stroke, I'm just going to concentrate on the PFO, leaving the other anatomy that alluded by the article before. So usually when we do bring the patients, they have to get through a proper collection. We do have a proper assessment to them in the cath lab and how to close them. From just a transthoracic, a straightforward bubble study by transthoracic, it can actually give you a very sort of like easy hint from the get-go. There is an element of a right to left shunt when the patient referred to you. Sometimes if you're lucky enough with a good transthoracic echo imaging, you can see actually some anatomical variation of the atrial septum and aneurysmal dilatation. We do in our practice have a transesophageal echo appointment as an outpatient for them, so you can really do a bubble study and you can assess a right to left shunt positive like this patient has, and then you can basically direct him to the cath lab and when you do an assessment and try to probe that defect, and then you will be able to close it. So just Some of the process of closing it, I'm not going to go into detail, just going some of the complete evaluation. We have to be very careful on this patient. A patient came to us for possible PFO closure, but you have a lot of left atrial appendage clots that you will need to be evaluated, need to be assessed differently, not to go ahead and just push it. Sometimes you get a false impression that this patient has a PFO or a stroke when you get in detailed and in the cath lab and you assess them under more controlled, more directed catheter to the PFO, and it will be negative, so you don't have to go further. That patient that I presented to you, the 39-year-old or 37-year-old, is actually had a very difficult septum. Some of the challenges that we have, you can see how the septum is just probing it. I did not yet cross. You see the septum itself, aneurysm reached almost all the way in the middle of the LA. Some of these techniques that you need to modify your process and go transseptal, and then you will be able to close it. Other modality that has been helped and evolved with the PFO closure is the intracardiac echo. You need to be careful with the flipping images, that it's different images. This is the right atrium, this is the left atrium, and you will try to kiss. This is kind of a tool that you will be able to use, especially when a patient is going to be difficult intubation. Some of the patients that are scared from anesthesia, we usually advocate to go for that. And it's basically a very straightforward assessment, though, with an extra sheath. So after the closure, and what kind of assessment tools? Okay, I have the patient, you brought him into the cath lab, you close it, okay, we got rid of the shunt. There are other newer data that even when you're closing these data, there is still some residual shunt. There are some studies that have come recently from Mass General, from Ning group, where they actually studied the homocysteine level in these patients. And when after closing the PFO, the homocysteine goes down and dramatically, but when the homocysteine did not improve, they restudied these patients and found actually there is still residual shunt. So maybe the homocysteine level as a blood work after closing PFO maybe is a tool for us as evaluating them. So this is a question that are going to be coming to our mind, especially down in the road, which I can see when you close the PFO with the device. Is there going to be a complete resolution of the PFO or not, and what kind of a tool you're going to be assess them? This is the same. Other from our group as an interventional group with a big, proactive and getting into the PFO, the SKY committee or the group expert has actually published a beautiful guidelines for cardiac centers and how to approach this, what kind of a training you need, what kind of a staff you need, what kind of a supportive equipment you need. And not only that, but also they also build up a quality module for such a patient that need to be followed up and need to be monitored in these patients. So from our perspective in our cardiac center, we have built a great collaboration with our neurologists. We built a new sort of like a floor map or a floating map for patient going through the neurology and cardiology. Part of the assessment, what kind of assessment they get before being referred to us, including blood work and blood analysis. All of these are built up within our system, and hopefully that will streamline these patients. Coming to the interventional table, all of this workup and has been already completed. The new guidelines, which has been published in the 19th last month from the SKY group, is actually had many sort of like great involvement from many different groups, including having a representative. Stephen came from the neurology, American Neurology Group. In addition, had addressed mainly 5 questions. The percutaneous PFO closure without prior PFO stroke, whether with medical therapy or not. PFO closure with antiplatelet with a previous stroke, PFO closure with versus anticoagulation with a PFO-related stroke, and percutaneous PFO closure with lifelong anticoagulation versus antiplatelet with the PFO-related cross, and in addition to addressing one question, whether you will need the dual therapy within a month or extend that beyond that. So from clinical questions, whether the first question has to be addressed, included all of looking at all of these kind of different variety of patients, whether they have prior decompression illness, atrial septum, aneurysm. So the aim of here is not anymore looking at the atrial septum aneurysm. It's not looking at the atrial septum morphology. They are actually got more of a generalized statement regarding this. In addition to patient, whether they are between 18 and 16 or more, older than 60, presence of atrial fibrillation, in addition to the Rope score, whether it is available or not. In addition to presence of previous stroke many years back, how it's going to affect you when the patient comes to you with a PFO which was newly diagnosed, in addition to other associated lesions. In that paper, on that guideline, they applied a new grade system, which is the grading of recommendation assessment, development and evaluation with certainty and the interpretation, whether it is a high or very low. In addition, with that applying the grade system, the strength of a recommendation, they actually grade it whether it's a strong or a conditional. With that in mind, including patient perspective, the clinician perspective, the researcher perspective, and also the policymaker. So that guideline came taking care or addressing all of these entities with strong or conditional requirements. So going back to the guideline panel formulated and prioritized clinical question in the population intervention companion outcome format, the PICO format. If you look at the question 1, for example, regarding the percutaneous PFO closure versus medical therapy, whether the patient antiplatelet or anticoagulation without a PFO-related stroke, not really much of a strong recommendation to close it with the strength of recommendation and the certainty of evidence. But if you look at some, for example, I will just give you highlighted here with the orthodoxia syndrome is actually the guideline recommended to go ahead and close it because of the symptoms and because of the collective opinion that we have. So data did not, the conclusion from that question 1, data did not support PFO closure with scuba diving, TIAs with no stroke, thrombophilia or DVT or high-risk anatomy. So that will take care of our atrial septum aneurysm that in the past we used to contemplate or take in consideration. Panel did support PFO closure for orthodoxia platypnea, and the panel supports PFO closure with systemic embolism and has no stroke. So this is sort of like a new sort of like paradigm that we are going to be intervening and going into. Question 2, whether it was antiplatelet in adult with a prior stroke. So basically has a lot of input from the randomized clinical trials, whether there is between the 18 and 16 recommended to go ahead and close it, even older than 60 patient. But when you have patients with atrial fibrillation and ischemic stroke, the group did not suggest or were against routine closure. And regarding the prolonged stroke and the patient late presentation, did not have really a strong recommendation for what to close or not to close. Going to the question 3, whether it's PFO closure versus anticoagulation therapy with a prior stroke, the panel, although anticoagulation may be effective in preventing recurrent ischemic stroke with PFO, PFO is advised. All of this with the question number 4 because of patient compliance. So taking the patient and the researcher input in that guidelines actually made a shift from our interventional group to go ahead and proceed with closing it, knowing there are issues with the compliance and regarding this patient. Coming back to the question last one regarding whether you do dual antiplatelet or single, there is really no strong recommendation to go with yes or no. So in conclusion, the newly published guidelines help the clinician, patients to make a decision, and especially the patient, about management of patients with PFO, including transcatheter closure and its alternatives. Patient comes in with a scuba diving. He thinks his scuba diving is his life. He has a lot of decompression illnesses that he cannot tolerate it, keeping him out. He is well informed about the decision, though the guidelines did not support close, but he want to close it, so he lessen the decompression illness. We can proceed with that caution, with that in mind. Build and expand policy, education, and advocacy to describe knowledge gap, we have to understand there is a limitation always. There is no randomized study that will really give us a hint unless we expand on that. Support interventional cardiologists and neurologists. We saw this paper is actually one of the lead papers that you get another group with you and be online with the recommendation, especially the neurology group, and having your team with you. If you give me just 30 seconds, please, the last line.
Don't give him.
Yeah, Zaid. Help a patient clinician to achieve the best evidence base. And I think this is very important. This paper alluded to having the policymakers and the patient getting involved. And I appreciate you listening and giving me the time. Thank you.